Yeah, we don't know how long.
So Virginia, can you kick us off here and we'll kind of
Yeah,
go from here?
I just thought I'd just say a few, just repeat sort of the description of what we're doing here today. The purpose of this virtual consultation session is to build upon OPA's efforts to respond to the ongoing discussion many association members have had as we all have had to develop competencies in telepsychology. This session will emphasize telepsychology practice issues across the older adult populations. So today we have two experts in the area. Mary Lewis, Ph.D., ABPP, is an assistant professor in the psychology department at Columbus State Community College and leads their service learning program for the human growth and development across the lifespan course. She is one of 2 diversity and inclusion professional development fellows on campus. Dr. Lewis is co-owner of Reflections Health and Wellness and provides psychotherapy and assessments to long-term care and nursing home residents. Dr. Lewis received her BS in general psychology from Kansas State University and her MA and PhD in counseling psychology from the University of Akron. She is board certified in geropsychology. Dr. Jerome Gabis, is that how you say? Yeah, Ph.D. is a licensed clinical psychologist who completed doctoral training at Wright State University in Dayton, Ohio. His professional interests and experience include 25 years of helping older adults and their families address a variety of conditions, including chronic health issues, depression, anxiety, and dementia. He also maintains a general practice in psychology at Legacy's Cincinnati Clinic. He has been recognized by the Alzheimer's Association as a distinguished volunteer for his role in facilitating caregiver support groups since 1992. And I'm not sure which, or Mary, are you starting off?
I don't think we had a specific plan.
Okay, all right, okay. So
I have an idea.
okay.
I have an idea. Well, I'd be interested in understanding why folks are here, why folks are why attending this teleconference, and then we can go from there. I also have another idea that I'd like to maybe propose later on, but we can kind of see where we go. I'm interested in coming to and attending this because I'm finding that this is a completely new experience for me, and I'm interested in understanding how other people are doing it. I would not call myself an expert. I just say I haven't died yet, you know. I'm still alive, and I'm still kicking, and I'm still doing what I'm doing, and I love what I'm doing. But this is all new for me, and if we had had a crystal ball last year, you know, at this time, on May 13th, 2019, what would we have said, you know? This is not what we would have anticipated. So I'm interested in learning and supporting my colleagues in as they provide these kind of services. I know that in terms of the statistics, the number of people who have this COVID, 45% of them, I think something like that, reside in long-term care settings. So this is a hotbed for the development of this problem, and and it's the chief organizing factor that the morning stand-up meetings are all about. This is all about how to manage this problem and how to keep our people safe without being so restrictive. You know, you could put them in bubble wrap, and I would. It's just it's going to be with us for a long time, and so that's why I'm here.
And I'm with you. This is definitely new territory. I was used to being able to go into a community and see the resident face to face, and now with the telepsych, you know, with our aging population, with the geriatric population, there's barriers in being able to effectively execute telepsych based on their knowledge, their understanding, application of technology itself, smartphones, laptops, like that's my major concern, is that they still need our services, but how are we going to do this in a way that they can participate in it and really benefit from it based on maybe limited knowledge and ability to use this technology? That's a major concern for me. And so I'm interested in seeing how other people are kind of navigating through that and kind of working out glitches, so to speak.
So much of technology is sitting next to somebody shoulder to shoulder and saying, now, what are you seeing on your screen now? How do you do that? Let's kind of try this, you know, and it's so experiential and so personal that it's hard to do from a distance. You're right.
Yes.
Yeah, I have had interesting experiences because I'm probably one of two that I know of private practitioners in Athens that sees Medicare clients. And so I have two of my clients are in early stages of dementia and really unable to operate any kind of, so I've been so grateful that I've been able to talk to two people over the phone in the last week. Now
Hallelujah.
that allowed that, you know, if it's a long-term client, I think talking on the phone is just fine. But I don't know what you would do if you had to bring in new clients. And one of my clients that's in early Alzheimer's, her husband was able to set her up with a FaceTime call. Fortunately, he had an Apple phone, and so did I. But if somebody's got a different kind, you can't do that. But he set it up and then left the room and left her to talk with me. But at the end of the session, she couldn't figure out what to do to where she'd laid the phone and, you know, and things like that as she was trying to write down when we were going to next meet. So it was a challenge, but we did it.
Yeah. I think that's such a perfect thing to think about, is like if somebody has some mild memory loss, like helping them navigate, like holding a phone and what buttons do they push, and you know, there's some research that shows that telephone assessments and telephone therapy is just as effective as in-person work and telehealth work, but it's really hard when there's that memory piece.
You're right.
I actually have a client who's cognitively intact and could not figure out the doxy piece. Yeah. So I went into the facility physically last week, and I've once a week been going in and donning my PPE, and I went to her room and with her consent, took her computer, set it up, left the link there, and then gave it back to her after I wiped it down. And I said, now you're set for next week's session. Just open the screen and I will push the button to let you in. but it's, you know, these multiple technologies, like starting somebody with Doxy and then it fails, right? Something happens on their end, and then moving to FaceTime or moving to a phone call, and how do you document all that too? I thought when I started in geriatrics, I did therapy in a lot of bizarre places, like hair salons and bathrooms and closets, right? Now
shower
now we've
spas
got
or
phones and telehealth and FaceTime and outside of windows. It's just an evolving thing. What about you, Elisabeth? I see you've joined us. You're on mute. You're on mute.
Chris.
Okay, well, thank you for introducing yourselves and inviting me in. I have a sort of unique niche. I have, for a number of years now, practiced out of a sleep center, and I'm highly, highly specialized in sleep. So, not surprisingly, a lot of my patients are older people. Sometimes much, much older people, and usually quite highly functional. I mean, one of my patients goes polka dancing with his girlfriend, and he's 90, but he still can't sleep. But we've been working on that on and off. But the pattern of practice is a little bit different because a lot of my patients are seen in a tandem appointment with their sleep physician or their neurologist. So they don't always perceive me as their therapist. I'm sort of I mean, they call me doctor and they know I'm a psychologist, but they don't have that sort of sense of continuity. It's, you know, they see their sleep doctor every 3 months or every 6 months or even once a year, and then they might see me for 1 to 2 or 3 sessions. I see a lot of caregivers because there are certain neurological disorders that give rise to certain very dangerous sleep issues, and circadian problems and things like that. The tele challenges are multiple for me. First of all, I've had to learn them. Second, I've had to put in place a lot of things that I was able to rely on the sleep center for, like digital fax, hush mail, things like that.
So you had to like build an infrastructure.
Yes, and I'm still building that infrastructure. And it's been what, 8 weeks? The telehealth guru, I always forget her name, Mayhew. Marlene says, and I actually had been looking into telehealth and taking a course here and there as it was available over a several year period. But she had said, when you're ramping up to telehealth, expect to spend 50 to 150 hours getting your practice ready. That's a lot of time. And that's a lot of time for somebody who's doing it by themselves. And
Right, and for me.
Yeah, I was a tech wizard in 1977 when I did orphan programming. That's obsolete. That's Stone Age, okay? Although they're bringing some, I mean, I could write a linguistics program. Yeah, probably.
Hey, they're bringing back vinyl, Elisabeth. They're bringing back vinyl, so you're still.
Yeah. So anyway, this has all been very challenging. I'm very aware that it is really not great to be like chasing patients. And with older people, they can feel pressured, which is why, of course, they get taken advantage of. And so I want to let them know that I am available and that we can talk on the phone. But it's an interesting position to be in because I don't want to be like, oh, well, here I am and you've got to meet with me, because they can feel that push. And it's like, I think that's a really bad way to go. So
You
I
have a specific question, Elisabeth, that you would like the group to
yeah.
address?
Okay, so this is a problem. This is a somewhat I have a patient who is 101 years old, and she lives at home with, now she's not 101, that's somebody else. That's somebody in my family. She's 98. She lives at home. She has a family member who lives there who is marginal. She has a lot of home health help. The marginal family member I just learned this 10, 15, 20 minutes ago, tested positive for COVID today. So now the home health, they don't want to come. What can I do for her? She has said if she ever went to a facility, she would commit suicide. She hates anything institutional. She has visited friends, gone and played.
So you see her via telehealth.
I have just checked in with her by phone, not even just to sort of, I think somebody called it a well check.
Yeah.
And when I called today, I mean, I'll call her and she'll say, I don't know what I'm going to do. I'm losing my mind. I'm confused. And like, she knows who the president is, the day of the week, what she had for breakfast. She's not losing her mind. She's just anxious. She called and said, we have COVID in the house and now my aides are quitting. What am I going to do? So that puts me in the position of being the unpaid case manager because there's nobody else to do it. The relative is marginally competent. And the thing is, I think he has people who he can make double up in their homes, and then he could move into one of their homes until that's over, and she could maybe get her aides back. It's not my place to orchestrate that. These are really challenging case management issues that transcend psychotherapy, but they have to be informed by psychotherapy. And they have the telehealth aspect. I am not going to show up there. That's for sure. You know, I have my own susceptibility.
You can't get paid for doing this case management either, can you?
No.
Yeah.
It sounds like this might be kind of an overall question of when is it appropriate to do something via telepsychology and when is it not? You know, because I think we don't want to get into specifics of, different cases, but we want to kind of look at kind of more the broader issues that may apply to multiple cases. But it sounds like that's really what you're kind of dealing with in that situation.
Right.
Yes.
And I think one of these issues here that you're directly asking is, what do I do when there's the potential for neglect? And neglect is a reportable elder abuse issue. And so here you have a person who potentially could be neglected if the family member is too ill to take care of them and the home health aides will refuse to go in the house. So in general, if this was a client of mine, I would get her consent to call the area agency on aging and ask them to act as the case managers, because that's what they're there for. They are a repository of services, and they can help her with moving if that's the choice, or they can help her stay independent, or they can find a home health agency who's been working with COVID-19 clients and will get her set up. So the issue here is that it's really close to a reportable incident for neglect.
That's kind of how I've been feeling, indeed.
Yeah. But if you take it because it's not yet neglect and you have her call the area agency on aging, or you call them and say, this is the person I have, they're really meant for community dwelling adults to be that, to connect those services for that person.
Yeah.
Absolutely. Go ahead.
I was saying, Jerome, do you have anything that you would do?
I would think that some of your services are billable. some of your services are billable like that. If she's referred to you for a mental health reason, and you do a diagnostic interview and you do an assessment of her mental status, and or if she's already an established patient, you can call some of what you're doing as psychotherapy in terms of helping her adapt to the situation, problem solve around getting the care that she needs, communicating with her relative there, whoever that might be. So it's not, especially now that Medicare has listened to the community of providers to say, look, we need just to be able to talk to people on the phone, not just to have the video capacity. So Medicare is now paying for those things, so you don't have to use the telephone check-in or wellness checks to code. So you can use the 90832, 90834, 90847, 90837s with the 95 modifier to indicate telehealth in those cases and get paid for your work.
That's really good to know. So that's the billing side. Then there's the like doing the right thing side that Mary has focused on.
Yeah.
It was actually several weeks ago, and I don't want to make this all about me. So if, I'll push myself to the side if I am, but it might be other people's experience. The way she even got this set of aids was somewhat efforts on my part of really sort of pushing it and telling the relative, you need help, you need more help than you have. And they were hard pressed. She'd had a fall, and and that fall wouldn't have happened if people had listened to me, but they didn't. I wasn't invited to consult on that. So I said, you are going to need more help. He called like 4 agencies, and they were so short staffed. So I have a friend that has an agency, and I called her and she said, I'm short staffed, but I have a friend who charges more. This is mainly going to be private pay, and I think she may have the staff for this. So he called her and got them on board. So I don't know what other resources we're going to find. I've done a lot through the area office to get people into like recreation services and activities and meals on week, those kinds of things with them in my office, because it is related to if you're not eating, you're not going to be sleeping. If you're sleeping during the day, you're not going to be sleeping during the night.
So much of geriatric care is, people don't come with nice, discreetly defined problems, nice wrapped up into packages. They come in, they're in a mess, and you're often the first one on the scene, or the most competent person on the scene. So our temptation, and it's our call in a sense, is to kind of get some order out of this chaos and get the people the help that they need, and to, you are a social worker as a geriatrician, as anybody who's done this for any period of time would attest to. Okay, so let's, I have a few questions about that we might be interested in addressing, unless Latisha, do you have some specific other things that you would like our group to address? Do you have anything?
Not that I can think of. Like I said, my struggle is just kind of like with the technological issues and just the population that we're working with, and really how to navigate through that process, not only with them, but even the community and the family, and how we can really work together to get these services to the people that need them, because there just are a lot of barriers with knowledge of and ability to use, these technologies. So that's my concern.
I could address that if you don't mind.
Absolutely.
In the facilities that I go to, that our group goes to, we probably go to about 20, maybe 25 different facilities that my group goes to. And we develop good relationships with social workers.
Mhm.
That's they are our social workers. They are our principal contact with the facilities. If or a clinic manager, for example, if someone is independent living, they might have a clinic manager or so. And so, for example, this morning I had 3 sessions at a facility. I'm right now in my bedroom. This is my quarantine bedroom here. I've been quarantined here for, this is my 18th day now. But I'm out of quarantine as of Monday.
Wow.
But I've been doing sessions from my home here. And the social worker, I give her a list of people that I want to see, and I give her my schedule, and she's very accommodating to, she does the technology stuff, and she sets the laptop up. I send her a link. It's a platform within our practice management software that we use. And I set the link up and I send it to her email, which is on her laptop. And she positions the laptop in front of the client. She makes sure that the volume is up. She makes sure that they can hear me. I can hear them. She turns the TV off. She closes the door. She asks if, you know, and most of these people are in private situations, but she asks if the person has a roommate, if they mind, can we do this, you know, even though it's impossible to get out of the room because both of the patients are bedfast. So she is my, I would call her a confederate, and
Yes.
she helps, and I have been pleased. I've been surprised and pleased and humbled by the degree to which these gals and guys are willing to do this. I've had some administrators in training who are really tech savvy. This young guy, he did it very easily. And other people who are not social workers, but who are activity coordinators,
Mhm.
you know, that they have been very, very helpful. And I can't tell you how you feel like you're working with a team. You know, it's a good feeling. You have a feeling that we're working together for the benefit of these folks, and that's how I do it. I don't know how anybody else have any other remark about that.
Yeah, I have one woman who is in an assisted living setting, and the staff there for a while was saying absolutely nothing. And then finally they agreed that they would help her set up her computer so she could do Zoom, but she didn't want to have to learn to use Zoom. And so finally we've got permission to just talk on the phone, and she is very happy with that. But the staff there is confused by it because we made the arrangement ourselves. You know, we picked a time, and you know, and she was to call me, but then she got distracted and didn't get there to her room when I was supposed to call her. And so I had to call the staff to find out where she was, and they were totally confused. They thought maybe I was a psychiatrist or something, or going to prescribe medicines. And no, this, you know, so it gets a little complicated when you're trying to deal with staff there who don't quite understand what's going on. And
So the normal problems, like sometimes, let's say you would arrive at this lady's apartment, and let's say she's, all of a sudden she has to use the bathroom, you know, which is not uncommon. This is,
right.
and she has to use the bathroom, or you thought you had the appointment time set aside and she's still in bed, you know, and they haven't changed her or got her up.
Yeah.
So all these normal problems that you experience with the geriatric population are all the more exacerbated because you're not there to problem solve yourself.
Right. And so I've got to call on the staff, and I hate to impose on them. So.
Yeah. One thing I've been doing, which again, my caseload is lower than other people. I have 3 facilities I go to right now, but I am calling patients ahead of time, the day before, and reminding them, or sending an email the day before.
A day before won't help.
Yeah, it's hard if they don't have an answering machine, or they don't know how to check their voicemail, or
problems. You get her off of the short-term memory stuff and she's fine. But boy, like she knew she was supposed to be back at 11 for the phone call, and she went to an exercise class, and on the way back from that, she smelled the food in the dining room and stopped to eat. Wasn't in the room when our time was. So.
Yeah, that's hard.
Yeah. And she realized afterwards, oh, that's what happened. So.
I was interested in asking you all is if, certainly telehealth has changed how we are practicing. And I'm wondering if telehealth has changed you. How much has telehealth changed you as a provider?
Well, I'm actually kind of surprised at how well it does go when I'm dealing with people who can manage the technology. So it's been kind of interesting, and sometimes you're kind of seeing where they are that you don't ordinarily get to see. And they can show you things that they want to show you. So it kind of, it works a lot better than I expected it would.
What did you think would happen?
Well, I didn't know. I'm just not used to, you don't see the whole person, you only see their face. And so you're missing some data, but it went surprisingly well.
Well, and I would say for me, it's definitely kind of forced me to, even for myself technologically, to really, learn how to utilize different kind of forums that I wasn't really aware of. And even now I'm still kind of learning. Even I didn't do a lot of Skype before, anything like that. So for me, it's just really kind of forcing me to, kind of learn that competence as I go, as it relates to technology. And there is that kind of element that you're removed from when you're doing telehealth, as opposed to being present with the person in the room. And I know even for myself, just doing telehealth from home, there are definitely distractions. I have 3 cats. And so from time to time, my cats will come up here and I'll have to shoo them away, or, there'll be maybe noises and creaks and stuff like that. So even kind of navigating through the distractions, and, with children being home, because they're not going to school, and trying to say, well, I have a telehealth session, even though I do have my little Bluetooth speakers. To me, that's been a challenge too, is trying to control extraneous variables in my environment.
I've been going to my office actually to do sessions rather than doing them from my home.
My home office is, it's got huge windows, which don't accommodate curtains very well, and boxes of clippings and lots of locked metal filing cabinets of clinical records. It's not a great place. So I carved out part of one of my kids, they're all grown up and out of the house, bedrooms, where I had actually put a poster from a really significant sleep conference that had a tiger on it from the Columbus Zoo back in the 80s.
Is it right behind you there? I see it there.
Yeah, it's one of those bittersweet stories that I won't get into, but anyway, this is okay, but it feels stark. It doesn't feel like me. My older patients, I always, in our offices, it was grueling for them to wait for the sleep doctor and then see me. And so I always say take off your shoes, you know, put your feet up. Do you need ice water? I can't give them coffee. It's a sleep clinic, you know, just let's be comfortable. I can't do that. Or who is that in your waiting room? We haven't been with them before. You want them to come in? No, that's my daughter-in-law. I hate her. Okay. She doesn't live with you. She just drove you. I don't have that ability to finesse things. And then the other piece is, even though sleep is
So how much of your ability to finesse things is reduced? By 50%?
90%.
90%?
Yes, and because people will say, oh, I'm wide awake, I'm doing so well on this medication. And meanwhile, the sleep doctor will say, she fell asleep 3 times talking to me. And they don't fall asleep talking to me, but they will yawn. And I'll say, is like that a yawn of boredom, or is that a yawn because we're getting on something you don't really want to talk about? Even though sleep is very behavioral, I do a lot of little gestalt things, like Gestalt 2 chairs, Jenlen's focusing. I do not want to do that where I have a diminished signal. I can't really see if the pupils are widening or constricting. I don't know how I would handle a weeping event. Weeping events have been studied extensively, and you need a lot of markers to understand them. I can't get those markers at this point. Maybe with enough practice I could, or if my population was more homogeneous, but it's not.
So these kind of the information that you have, and not only the information that you get from them, but what you can do for that person, or interpret their behaviors, or you say, I think that's a good word you use, to finesse the situation. You're very limited because you can't reach into that, you can't reach into the medium.
It's very limited in certain ways, but it's also very opening in other ways. And that is, anxiety is can't quite explain it. It's evident in different ways and becomes more of a focus, whereas it was denied before. I'm not anxious, I just can't sleep. Well, what do you think about before you go to bed? My bills, my car, my prosthetic leg that doesn't fit, my boils, whatever. Well, I'm not anxious. Now they'll say, I'm really anxious. I can't get in to see my doctor. I can't find my thermometer. I can't see the thermostat because I broke my glasses and it's freezing in here. The anxiety is more, it's sort of like peas and carrots anxiety. It's right there in front of me and I can deal with it. Whereas in a regular situation, face-to-face in the office, it was, no, I'm not anxious. I just can't sleep.
What do your people tell you about, what kind of feedback are you getting back from your geriatric population about using telehealth? Or do you guys give them a choice to whether they want to use the telephone or the video? Or what kind of feedback are you getting back after the sessions are over, whenever you say, how was this for you?
One is great. One is good with telehealth. She is a university level person, so she started at a higher level, and the cognitive loss is bringing her just closer to high average rather than starting at average and going down. She's loving it. And she's loving it because she has like 3 sleep disorders and she's always afraid she's going to fall asleep driving. So she's like, I hope we can do this in the future. This is so cool. I love it.
Yeah.
But she's also very ashamed of her environment and how much stuff is piled up and things like that. You know, the refrigerator is like tied with a rope. So the others, we have not been able to succeed with video. It isn't going to happen. And the telephone, some will not turn off the TV. They'll say, I don't know where the remote is. I think it might be under the chair and I am not going under there. So they leave it on 24/7, which is of course not good for sleep.
How about your other experiences, like Mary? What are people telling you about how are people benefiting or enjoying or engaging in the process with you, Mary?
I think it just really depends on the client. Some of them are so proud of themselves for trying something new. And at my facilities where all the staff are wearing masks, I get a lot of positive feedback. They like seeing my face, and it's like the one person they get to talk to. A lot of them don't have families, so I might be the only time they get to talk to somebody face to face. And some of them are loving it because they get to peek in my life a little bit. I will say I'm working from my home office. They'll see my cat, like you, Latisha. They'll, you know, they comment about the blanket that's behind me. So I think, while it's not what I would do like you, Elisabeth, I like to tweak the environment. I'll straighten a blanket, or I'll bring water, or I'll pat somebody's hand. But here it's, you know, you're stripped down to words. It's interesting because the cognitive part of therapy has been a little bit easier. You know, it's easier to focus on just what they're saying and not be distracted by the roommate or the staff or.
Do you disclose more? Do you disclose more about yourself to gain rapport? And
I mean, I always have as part of my in-person work, but I think them getting to see kind of into my house, even though it's a very innocuous corner, for some reason that connects some of them. I have had a couple of clients who have just flat out refused to do telehealth, period. I went in with consent forms. The last time I went in person, I talked with them about the pros and cons. And 2 of them didn't even want to do telephone. The one lady was very adamant. She said, I will not sign this, and I will not see you until you can come back to see me in person without a mask. And she understood she's not in crisis. And every week I talk to the social worker and I ask her about this client, and they're making sure she's stable. But that's been the other challenge, is that I have some folks who will adamantly refuse to do it. So in that respect, it's been a lot harder.
Yeah, my experience has been that people in general, though, are finding it better than they expected. And I'm finding it better than expected. I think with the older population, though, I see some people who are in their homes, but, you know, some, like in the nursing home you're describing, you know, I have, you know, another family member who's setting things up for them. They're not completely independent with doing things. But the thing that's most frustrating for me is internet connection. Because especially with the older population, they're not paying for a higher amount, you know, a higher plan, you know, so their internet connections iffy. I've often had sessions with people where halfway through we give up on the video and we go to telephone.
Or you use the video, but there's no voice, and so
Yeah, I've done that too. Yes. You know, I try to document it. You know, I mean, what can you do? I was so glad to see that Medicare went to,
Oh boy.
it doesn't matter which modality, because, what do? Bill half the session for the video and half the session for telephone? It was ridiculous, so.
That saved a lot of psychologists from going to hell right there. I'll tell you.
Yeah.
And I'll say, Virginia, one of the other things that I've been thinking of is some of my independent living folks they're on restricted phone plans. And so if I use video on their phone, I'm using their data.
Yeah.
As opposed to when I'm on the phone, I'm just using their phone call. And so I had a client run out of data mid-session, and we had to convert to phone. And then I felt bad because she's out of data for the rest of the month because she tried to have telehealth with me.
Right.
So I think those are things we wouldn't have to think about. And our younger clients probably are on unlimited plans. They don't, they live a different world.
Right. I'm going to ask you guys this question here. Okay, so we started out maybe with a crystal ball. If we would have, last year at this time, even last year, or even January at this time, to see such changes that we've seen in just 3 months, 4 months, 5 months now. So we've had to gear up, we've had to learn how to build, we've had to learn how to code, we've had to learn how to tolerate all this ambiguity, things changing from day to day. We've had to make new liaisons in the facilities and teach our clients how to use this, learn how to use it ourselves, how to schedule our time. And, this is not going to change. This is not going to change with the geriatric population. So if you would have a crystal ball, let's say next year at this time, question one, would we still be able to be using Zoom or Skype or the non-HIPAA compliant platforms? The second question, will Medicare then change? When the dust settles, will we be able to go back to the old methods of billing? Is Medicare going to tighten down the screws on this because it's getting to be too easy to do it, So if you would predict what's going to happen, what kind of prediction would you make? Make one prediction. What kind of prediction do you think will be happening a year from now? Telehealth and geriatrics.
Well, I think we're going to see major changes in the nursing home industry because a very large portion of the population that's paid for is going to die. 40, 50%, maybe more. So that industry, all you have to do is look at Welltower and look at Healthcare REIT and those companies. They are going to be shutting facilities and closing them up, or they're going to have to change how they're used. So how are they going to be used?
Yeah.
We have a bumper crop of people with opioid problems. Maybe they'll be converted to that. I don't know.
Okay,
But
so facilities themselves will be changing.
the facilities
Okay.
will
Any
change.
other
I
predictions?
predict that.
Any other? Elizabeth, we'll ask if anybody. We don't have so much time left.
Yeah.
How about, does anybody else have any other prediction or any other?
I'm hopeful that they will allow telehealth and phone calls and so on into the future, that Medicare will understand that older people really can't manage this. And I'm not so sure that we're going to be able to manage seeing people in our offices very soon at all. I mean, I'm in the age range where I should not be seeing people.
Mm-hmm.
And most of you are, except for Tisha.
It's going to be hard to put the toothpaste back in the tube after all this is done. I think if they try to tighten the screws down, there's going to be such an outcry, and really it'll boil down to being an injustice to deny services like that.
I think that's one of the things is, they limited telehealth because they were concerned people were going to use it unethically and inappropriately. And bill for all these things. And I think they're going to see that psychologists are doing a good job and we're documenting. And my hope is that this is going to change geriatrics, where we're going to be able to see folks in their homes. We're going to see rural clients who don't have access to services right now. I will say, I really think a lot of it depends on who gets voted into office in November as to whether this is going to go back or not, and whether this is going to get worse or not. So my prediction is predicated on kind of what happens politically. But you're right, Jerome, as you know, they can't take it back. They will try. But I think we've shown that we can use this appropriately. So why would they take it back?
Right.
The answer to most questions is money. And it may be cheaper for them to have within a facility a staff psychologist, maybe somebody at a lower level, or a social worker that provides more direct therapeutic services and not, you know, the connecting to, you know, discharge and intake, that kind of thing. So the use of extramural therapy, I think we may see that. It wouldn't surprise me if that gets swapped out, and that will be a loss of livelihood for some people. But I would predict that if the answer is money.
I do think that this will make a great opportunity for people to be in therapy that otherwise would not have been able to be in therapy, you know, not being able to drive anymore, or being in too much pain to leave the house, or, you know, illness. So I think for the Gero population, this could be a really good thing. And obviously there's, you know, this threw a lot of us into something I wasn't planning I mean, I had done some training on telepsychology, but it was kind of like, well, you know, I know that's in the future, you know, and then, you know, the future kind of crept up on me fast. So anyways, but, you know, it's interesting because I have a number of psychologists in my practice who are, you know, over 65, and how each of them have dealt with, you know, having to do this has been interesting as well. So.
Well, thank you everybody for joining us. I know Michael had to leave for another meeting. It's now 8 o'clock, but thank you guys for spending your evening with us. I appreciate getting to see all of you and talk.
It's so
Thank
valuable.
you for having us. This was very, very
so
helpful.
valuable. I appreciate everybody participating and
And the support.
Yeah. Just knowing there's a bigger circle out there.
Yeah. Please stay well, everybody, and just take care of yourself too.
Yes. I was going to say, I'll see all you at convention, but I'm not sure when the next convention's going to be.
Probably not.
Because I want to see each one of you personally and see how you're doing and all.
Yeah. Well, hang in there, everybody.
Yeah. Thank you so much.
Thanks,
Thank
everyone.
you.
Okay.
Bye-bye.
Bye-bye.
Good night.
Good night.
Good night.